there, this is John speaking, and this is chapter 23. If someone calls 911 and they have abdominal problems, the number one reason is going to be pain or discomfort of some type. You already have an idea about the various organs, solid versus hollow and all that, but all these organs are wrapped in a visceral layer, and the visceral layer itself and the organs themselves have no real pain receptors. They can't feel pain. The parietal layer, which wraps around the inner layer, is very rich in pain receptors. So you can see, based on the anatomy, how the patient is describing their discomfort might give us a rough idea what might be going on inside their abdominal cavity today. Now, if you do encounter someone who has a dissecting aorta, remember the aorta is actually in the retroperitoneal cavity. It's behind all these major organs. It's back where the kidneys are, essentially. So if this organ is dissecting and swelling and getting larger and larger, and it's pushing on the visceral layer and then the parietal layer, they're going to get pain with this. But because it's back there, the pain's going to shoot through from their abdomen through to their back. And this, if you wonder why that happens with that particular disease process, it's because of the way the anatomy is set up. Now, types of abdominal pain. There's visceral and parietal pain. And again, listening to the patient, what they say, how they describe what's going on, will help us get a general idea of what might be going on. So visceral pain is caused by the organs that are swelling up. This can be caused by gas, disease processes, but the swollen organ is pushing out and it's coming into contact with the parietal layer, but it's a large diffuse area, and it leads to this dull, spread out discomfort across your abdominal area. They'll describe it as, it's really kind of a dull ache, and they can't really pinpoint exactly where the pain is. They're going to kind of do a little circle around their tummy. It hurts in this area right here, this general area. Also, as those organs do swell, there are other nerves inside the abdominal cavity, and those organs can push against those nerves, causing them to fire off. And they can send referred pain to other parts of the body. So let's say if you have like a gallbladder swells up, there's a nerve that runs right alongside the gallbladder. It pushes on that nerve and it sends pain to the shoulder, pain to the upper back, or pain to the flank area. This is called referred pain. It moves away from where the pain is coming from, essentially. Now, parietal pain, this is if there's blood loss in the abdominal cavity or there's infection in the abdominal cavity. And what happens is now the parietal layer itself is being directly irritated by this blood or by this infection. So now you get this sharp, localized pain. They can take one finger and point right to where it hurts. So you can see, if you listen to what they have to say, it might help you get a kind of an idea what's going on. Obviously, we're not physicians, we don't diagnose, but it might help us decide, how bad off this person is. Is it a bad case of gas, or are they bleeding internally? So peritonitis. Peritonitis is the inflammation of the peritoneal sac. Number one cause is a bacterial infection. This is usually seen in people who are post-operative. They've had some kind of abdominal surgery. They could have ruptured their bowel for one reason or another, through trauma or other reasons. And what's happened is essentially they have a bacterial infection in their abdominal cavity. They got really bad sharp pain because, again, it irritates that outer layer we talked about earlier. They have a distension or swelling to the stomach. They have a high fever. And they're really uncomfortable. They need a doctor. They need medications, possibly more surgery. The Markle test is a way to confirm this. Now, personally, if you're in a lot of discomfort, your tummy's swollen and your belly's all swollen and it hurts and you're miserable, the last thing I want to do is like palpate your stomach, like put my fingers on your belly and start pushing down on this. You're gonna not like me at all, and it's gonna hurt a whole lot. So the Markle test is you have them lay somewhat flat, you stretch out their legs straight out, and you take your fist and you slightly wrap their right heel with your fist. Sharp, kind of short tap on their heel. What that does is it can send a vibration up the leg, and it causes the I guess it causes the organs to jiggle. I guess the only way to put this, and it hurts to do that. So if you tap their heel and their tummy goes ow, that's a positive Markle test saying there's an infection going on in their abdominal cavity. Appendicitis is a really good way of kind of figuring out these pains, because with appendicitis, a lot of times you get both parietal pain and visceral pain with this. So there's the appendix right there. It's on the distal end of the ascending colon. It stores good bacteria and things like that. Sometimes bad bacteria gets in there and it causes it to get inflamed. And so this is an inflamed organ. This is swelling up. And so initially these people get a dull belly ache, somewhere around their umbilicus, somewhere around their belly button area. They start feeling out like they had a bad burrito or something. They got really bad stomach pain, but it's dull, diffuse. As this process continues, as this thing swells and swells, and once it ruptures and that bacteria spills out and the fecal matter spills out, now it starts to irritate the parietal layer. And now you get this different pain. It graduates into this now sharp and localized pain over a period of hours. So it starts out a dull ache in the center of the belly, and it winds up a sharp localized pain down in the lower right quadrant. Again, this is a really indicator of a possible appendicitis. Age group wise, young, healthy males in their 20s and 30s, probably most commonly affected by this, though I've seen a few females as well. Pancreatitis, you know what the pancreas does? It produces those great hormones to control our blood sugars and some other things as well. Number one cause that I've read about is going to be diet. I'm sure there's other reasons why as well, but diet seems to be the big one. Really fatty diets, high sugar diets, high alcohol diets, and all that causes the pancreas to inflame, to enlarge, to swell up. This again causes initially a pretty bad dull ache. They vomit with these. They're going to be in a lot of discomfort. They're going to be pale. They're going to be sweaty. Not really life-threatening at this point, but really uncomfortable kind of patient. And if you listen to what they have to say, more than likely they probably had the 3 burritos last night and the 2 steaks and the half liter of beer and all that other great stuff, and it's coming back to them today. This is cholecystitis. This is gallbladder and the inflammation of the gallbladder. That green thing in the picture right there, that's your gallbladder. It stores the bile that's produced by your liver. The bile ducts get blocked and this thing starts to swell up. And again, it starts out as this, diffuse kind of dull ache in the upper right quadrant. But again, there's that nerve that runs down alongside this. And as this thing swells, it pushes against that nerve and it causes that referred pain you see in the picture in the upper right side there. Realistically, signs and symptoms are going to be the pain. They're going to be vomiting. Eventually, if they vomit enough, they're going to start vomiting bile itself. So if they say what they're vomiting up is green and bitter tasting, they're already into the bile stage, and you can pretty much guess this is cholecystitis. Demographically, so it's called the 5 Fs, and it stands for fat, fertile, 40, flatulent, and fair. So this is an obese female patient around 40, 50 years old. They're fair skinned, blue-eyed, blonde hair, fair skinned, and they're flatulent, which means they fart a lot. This is the main demographic for people who get cholecystitis. And again, it's predominantly diet based. In most cases, you might hear a history, again, they might have a history of what they ate, high fatty diet and like that. Gastrointestinal bleeding. So upper and lower, GI bleeds. So upper GI bleeds, ulcers are probably the most common. They're bleeding into their stomach. As the blood goes into their stomach, it mixes with the acids and it coagulates and it turns kind of a dark color, kind of a darkish mix of color, red and black. And what happens is that they wind up throwing up this black emesis, and it's called coffee ground emesis. It has the same granular look as used coffee grounds, essentially. If it's a lower GI bleed, this is commonly caused by diverticulitis. There's, obviously colon cancer, Crohn's disease. I mean, there's a number of reasons why this happens, but if it's something to do further up the GI tract, meaning like up into the large intestine, you're probably going to get black tarry stools because that blood congeals, it gets pressed together in the normal process of making a stool, and it's passed out the person in this black tarry stool kind of form. Now, if it's frank blood, it's red blood coming out. I mean, that could be something more closer to the anus, something that's near the end of the tube, essentially. That could be hemorrhoids or, some kind of colon cancer that's just a few inches inside the person. Biggest risk here, of course, is they're losing blood. They can go into hemorrhagic shock, hypovolemic shock. With that, so we're going to treat them for shock more than likely. They can be pale, cool, diaphoretic, low blood pressure, confused, disoriented, abdominal pain, all those things. Obviously, of course, is vomiting as well. Intestinal obstruction. So this is a person who is constipated. It turns into an impaction. This is seen a lot in the elderly population because there's decreased gut motility, which means the food moves more slowly through the body than a young person. So it has a chance to impact. Also, they might be on pain relievers. They might be on some kind of opioid pain reliever. Those also lead to impactions and constipation. Signs and symptoms: distension, pain. If you feel their belly, if you feel their abdomen, it's going to be distended and kind of hard, like a basketball kind of feel, hard to the touch. And if you talk to them, there's a history they haven't had a bowel movement for like 3, 4, 5 days. It's really a true emergency, because if this impaction ruptures in the abdominal cavity, it can lead to peritonitis, which can lead to sepsis, which can lead to death. So it's actually a really serious condition that needs to be treated pretty quickly. Transport is going to be mostly a position of comfort and transport to the appropriate hospital. Anemia. So anemia is just, they have less than normal red blood cell count in their body. People, who have things like pernicious anemia, this is probably the most common cause of it. So as a person gets older, they lose their ability, what's called the intrinsic factor, and they lose their ability to use or produce B12. So there's a deficiency, and it causes a reduction in their red blood cell count. This is rather very serious because they're basically now hypoxic, and their brain and other major organs suffer because of the hypoxia, and they can actually have brain damage from this and organ damage, ischemia to the organs from this if it gets really, really bad. So it's very easily treated in most cases. If it is pernicious anemia, they just get vitamin B12 shots once a month or every couple of months or so. But again, they're going to be pale. They're going to be hypoxic. I mean, they're going to look just really sick. They might have low oxygen saturation levels and all that. High flow too, of course, get that on board. Sickle cell anemia. So this is an inherited disease. And what happens is your normal round red blood cells, they become this sickle shape or the C shape. And once they're in that C shape, when they go through this sickle cell crisis period, they can't carry oxygen very well. And because they're in that kind of C shape, they hook together, they stick together, they can cause clotting. They get really bad joint pain because of these clots that back up in their joints and other organs. And very, very, very painful abdominal pain, joint pain. And that's what they're going to call you for. They're going to call you for just whole body pain, unfortunately. And they are hypoxic, so they need high flow oxygen. Don't give them a cannula. They need a mask at 15 liters per minute. And transport them to the hospital. The hospital gives them their transfusions and other medications to help them get out of this. But again, it is something you're born with and you'll always have. Hemophilia, this is the person, their clotting factor has been somehow impaired, the clotting cascade that we have to go through to stop bleeding. And so when they do cut themselves, it won't stop bleeding. They won't actually create a clot. So even minor bleeding, a cut finger, a cut wrist, a cut forearm, whatever it might be, if it's not treated, can be an emergency for these hemophiliacs. Luckily for us and for them, normal methods of controlling bleeding work. Direct pressure, tourniquets, pressure dressings, things like that. If this is external bleeding and you can get to their bleed, you can pretty much stop or greatly slow down their blood loss on the way to the hospital. The biggest problem, of course, if the bleeding is internal, this person's been in a traffic accident, they're hemophiliacs, they ruptured their liver, they're bleeding internally. All you can do is treat them for shock, rapid transport to the closest trauma center, and they can give them, I think it's vitamin K or other medications to temporarily give them a clotting factor to help them stop the process. So when it comes to just generally abdominal emergencies, we're not there to diagnose. We listen to what they have to say. We get what's called a differential diagnosis. We say, yes, I think it might be this, so I'm going to treat them in this direction or this way. Give them oxygen. High flow oxygen is fine for these people. Don't let them eat or drink anything. They're probably going to throw it up on you. Treat them for shock or look for shock and treat them if you see shock. Transport to the appropriate facility. If it's a dissecting aneurysm, you're going to want to go to a trauma center. Most all the other conditions are going to be treated in any emergency room is fine. Gynecological emergencies. So sexual assault. Unfortunately, predominantly female populations are affected by this, but male populations as well are sexually assaulted. I've been on at least 2 or 3 male patients that have been raped. So either way, it's exactly the same situation. It is a crime scene. So there will be police there. We have to think about evidence and collecting evidence. So the police will help you with this process. They will direct you to a hospital, or if the patient's not injured, they'll direct you to the police station or the police headquarters where they have a nurse waiting. They have a kit that they actually will, be able to gather this evidence in a legal way for this chain of custody of this evidence. If the patient wants to, tear off their clothes and take a shower, we want to discourage that because you got to tell them this can, obviously harm the evidence that could actually lead to an arrest and conviction of your assailant. We can't stop them. We're not going to restrain them from doing this, but we discourage them strongly. If they do tear off their clothes, put them in a paper bag, some kind of, like a, Trader Joe's bag or something, and bring them with you to the hospital or give them to the cop or something like that, or have the cop collect them if you want to do that. If they're not physically injured, our job primarily is emotional support. Now, if you have a female firefighter, a female EMT, a female police officer, I strongly recommend getting that person with you on board and be with this person to the hospital. If you're by yourself, do the best you can, but just realize they might not want you to touch them or evaluate them or even get vital signs on them, and that's totally fine. Just document this in your documentation. The patient was emotionally upset, did not want me to physically touch her or him, whatever it might be. Once they're at the hospital, of course, the doctors will be there. They'll call in, they'll call in psychologists and support people and all that. And it's very, you can only imagine, it's a very traumatic situation. We do the best we can. Don't be insistent. Just get them to the hospital or get them to where they need to go. Don't worry about getting vital signs or history. Don't ask them like what medications you take and things like that. If they're willing to answer, that's great, but otherwise, don't force it. Vaginal bleeding. So, number one cause of vaginal bleeding, it's non-traumatic, of course, is going to be a spontaneous abortion. This is the patient who's of childbearing years. They're pregnant, whether they know it or not, and within the first 3 months of pregnancy, the body rejects basically what's developed. It recognizes that this embryo is not viable and it washes it out with blood. So the signs and symptoms are going to be abdominal cramping, vaginal bleeding, and you can see there's a lot of emotional factors with this, because if the patient does know that they're pregnant and they're losing the child, it can be very emotional. In most cases with young, healthy patients, these are not life-threatening problems. When you get an older patient who's pregnant in their 40s and 45, 46, 47, there can be complications from these spontaneous abortions. But usually young, healthy females don't have those serious problems anyway. A lot of emotional problems involved here. They do need to go to the hospital, be evaluated. They do a DNC, it's a dilation and curettage. So they basically are able to go in and remove that excess tissue and clean everything out so that they can stop bleeding and all that. There are some times when a patient calls because they're just having a heavy period, possibly, and they get really scared. I fully understand that. Talk to them about their cycle. Ask them, is this your normal time of month? And all you're trying to do is decide, is this just a heavy period and they're having this issue right now and it's their normal cycle and everything's normal otherwise, or is this something abnormal for them? This might be a spontaneous abortion if it's somewhere between cycles, or something else might be going on, some kind of disease process might be going on. They should be seen by a physician, and you just discuss it with them to see what happens. So when it comes to just your primary assessment is ABCs, obviously oxygenation, talking to the patient, get their level of consciousness and all that. There are a lot of barriers because a lot of people, there's a lot of firefighters and medics and EMTs that are uncomfortable talking about conditions that are sexually related, reproductively related anyway. And the patient can be embarrassed. They might be reluctant to talk about the subject themselves. So again, don't push them. If they don't want to talk about it, if they don't want you to touch them, as long as they're stable and they're talking to you, why not just take them to the hospital, make them comfortable, let the doctor deal with the problem. Don't insist. They're already going through, who knows, a number of emotional things going on as well. If they're willing to have you do a physical examination, then sure, no problem. Just remember there's modesty, so make sure it's inside the ambulance or cover them up in some way if you have to expose any, obvious areas. But again, if they say no, don't push it. Just you can just document in your documentation. Renal emergencies. So these are the kidneys, obviously. And you have the ureters, which are those two blue tubes, that's funnels going down on both sides. And the urine travels from the kidneys and goes down those tubes into your bladder. And of course, most common thing people get with all this are urinary tract infections. Females more commonly than males. But in any case, usually bacterial infections start in the bladder for one reason or another. And and if they're not treated in a timely manner, they can travel up the ureters into the kidneys, causing a kidney infection, which is much more serious. So if someone has, pain on urination and a slight fever and blood in their urine, those types of things, they need to be seen by a physician and given some antibiotics. Now, people do get kidney stones. Kidney stones are created in the kidneys. They travel down the ureters, those two funnel-shaped tubes. There's different types. This is calcium essentially. And you can see there's round, kind of dull ones and there's really sharp ones. These are really, really, really painful. As this object is traveling down the ureter, every time it moves, it's agony. When it stops, it's just painful. But then it moves again, it's agony again. And they'll have pain in their flank. The flank is along the side of the rib cage, kind of like on the side of the back here where the kidneys are. They'll get this flank pain and it will radiate down from the kidneys. It'll wrap around past the belly button and go right into the groin area. They can have blood when they urinate. They can have pain in urination, and it's really, really painful. Males get these predominantly. Females, people, heavy drinkers, people who don't drink enough fluids, and unfortunately, even people who do drink a lot of fluids still get them. Sometimes it's what you're born with, what your mom and dad gave you, and all that great stuff. There are some of these that are so big they cannot pass. They have to be broken down with sonic treatment that breaks them into smaller pieces so they can pass. Kidney failure. So kidney failure, number one cause of chronic renal failure, so the kidneys have failed, is diabetes. So someone who's a type 1 diabetic, especially a long-term type 1 diabetic, they eventually, because of the really high sugar levels in their bloodstream, it causes the kidneys to wear out and they fail and they can no longer make urine anymore. Sometimes with trauma patients, especially someone who's a trauma patient or someone who's been burned, the kidneys will shut down temporarily to preserve fluid, to keep the person alive during this traumatic event and at the hospital. And it might take weeks or even months for the kidneys to restart, to start functioning again. In any case, both of these people need dialysis. They need to have their blood filtered mechanically through a machine. So to do this, there's a couple ways of doing this. If this is a person who has a chronic renal failure problem, the physician is eventually going to install some type of artificial graft or shunt in their non-dominant arm. Probably if you're right-handed, it's going to the left side and vice versa. There's two ways of doing this. They can take a vein from the person's leg and connect the artery and the vein in their forearm or their upper arm, depending on where they put it. And it takes a while. Once this is surgically implanted, it takes sometimes months for this to mature enough to where it can be used, where they can access blood so they can filter their blood. In the meantime, they'll have some kind of a central line, a Grosjean catheter or Hickman catheter. It'll probably be on their chest somewhere. You'll see it on their chest or maybe in their upper arm. And that's where they're getting their dialysis through temporarily until their graft or shunt matures enough. These are very fragile structures. So if you see the bump in the picture right here, if you see that bump, that's a mature graft. You do not want to take a blood pressure on that arm because you could damage that graft, and they're really hard. You can't repair them. They got to do another one somewhere else, and it takes like a long time for them to mature. So no blood pressures on those arms that have the graft or shunt. Now, when it comes to dialysis itself, you're going to go to dialysis centers quite a lot if you work as an EMT in the county of San Diego. The person who has chronic or acute renal failure, they're going to have to go to a dialysis center 3 days a week, Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, whatever it might be. And they got to get this plugged into this machine, and the machine pulls out all their blood and it puts it through this, it spins it through this centrifuge, and it separates the bad stuff and puts in some good stuff and puts it all back in their body essentially. When the person comes there in the morning to get dialyzed, the person is weighed. They go in the chair, they get dialyzed, and they make sure that the same amount of fluid was put back as it was, taken out. A lot of problems with this dialysis is, not a benign process. People can have serious heart problems with this. They can go into cardiac arrest. They can have low blood pressure because for some reason there wasn't enough fluid replaced with, through the process and all that. You can get bleeding from the graft sites with the shunt sites and all that. And if they haven't been dialyzed, regularly, if they miss 3 or 4 dialysis treatments, they can go into cardiac arrest because of hyperkalemia, really high potassium levels. Lastly, your urinary catheter. So this person is more than likely bedridden due to a stroke or other medical problem or trauma problem, and they have a urinary catheter. It goes up the urethra, so up the PP or up the urethra into the bladder. It's held in place by this balloon seal that kind of looks like a golf ball or a ping pong ball there. That's inflated and it's held in place in your bladder. And then the urine goes down the tube and goes into this bag. You can see there, and it's collected in this bag, and the bag has to be drained every day and all that. The problem with all these catheters is if they're in there too long, they can get really bad infections from them. Now they're supposed to be, if you work in as an EMT in the county of San Diego, you're going to transport people that have that Foley catheters or urinary catheters in place. And so consequently, you're going to look at them, make sure that the color of the urine is fairly normal color, a yellow or light color, whatever it might be. Make sure there's nothing in the tubing, the clear tubing that looks funky, this white wispy thing growing in there and all that. That's all a sign of this catheter's been in too long, and this thing's got some kind of fungal infection going on or whatever's happening in there. But normally it needs to be changed out every few months or every month or so, and a nurse would do this at the convalescent home or the private residence. When you're transporting a patient to the hospital on the gurney, the patient's on the gurney, you want to keep the bag below the level of the patient's bladder. Because if you raise the bag above the patient's bladder, the bad stale urine is going to flow back into their bladder, and it's going to give them an infection. So be careful about that. And it is attached to them, meaning make sure that that you don't forget it's attached to them, and you maybe the bag's attached somewhere on the ambulance, and you pull out the gurney, and you guys get the idea, a little kind of rubber band effect there, rather uncomfortable. Right, we're all done.